Greetings of the day. In this, we shall discuss about palliative extubation. Palliative extubation refers to intentional sedation of ventilator support to limit patient and family suffering. Usually, palliative extubation is performed on a patient who is unknowingly intubated against his or her prior expressed desires or diagnosed with a non-survivable medical condition after intubation that would not be consistent with his or her goals of care or desired quality of life. Or that is devastating neurological injury. These patients are ideal candidates for AD extubation. However, extubation must be performed in an organized and well communicated manner. Initially, the patient's end of life wishes should be confirmed with the patient's healthcare proxy. This discussion should include a family meeting that details the patient's current clinical status, prognosis, expected outcome, and post extubation protocol, and an offer of clergy or social work support if needed. And the act of withdrawal of life support and extubation can be emotionally and ethically taxing for a patient's loved ones in many instances. It is important that communication is compassionate yet informed and direct. If extubation is ultimately decided by the family and clinical team, it must be accomplished in a controlled manner to avoid patient and caregiver discomfort. Providing comfort, alleviating pain or family distress, and effective team communication should be the cornerstone of any palliative extubation. First, the treatment plan should be thoroughly discussed with the patient's nurse and respiratory therapist. A nursing staff must perform frequent patient reassessment to guide medication titration after extubation. Turning off the patient alarm can reduce unnecessary patient stimulation and family distress. Allow time for any paralytic to wear off by identifying spontaneous breaths on the ventilator so that the clinicians and nurses can assess the non-verbal cues of the discomfort, that is grimacing, tearing, and sweating. Medications aimed at managing dyspnea and pain should be initiated before extubation. And opioid infusion with additional as needed boluses available for the nursing should be titrated for signs of pain or respiratory distress. Anxiety can be managed with IV boluses of lorazepam or midazolam. Glycopyrrolate can be used to control secretions in the oral tract. And also, these medications should be part of a standard comfort care order set available for use in the ED. Once optimal comfort is achieved, respiratory therapists may deflate ET tube cuff and remove the tube as patient coughs or exhales. Oral secretion should be suctioned. Room air is generally preferred to avoid any unnecessary patient tubing that may cause discomfort. Supplemental oxygen may unnecessarily prolong the dying process. And but more importantly, seeing their loved ones encumbered with the medical devices may be more comforting to the family members. Patients may expire minutes after extubation. However, admission to a general medical floor or other private area where palliative care can continue may be warranted in instances in which patient does not immediately die. One of the most discomfort experiences for the family is to watch their loved ones experience agonal respirations, gasping, or death rattles. It is often helpful to assess the patient for these issues after extubation and before bringing the family back to the bedside. Additional analgesia and anxiolytics are often helpful in these conditions, and repositioning the airway with pillows under the shoulder and head may improve respiratory mechanics. Thank you very much. This concludes the palliative extubation.